Okay, let's unpack this. Welcome to the deep dive. We take your source material, could be articles, research, maybe your own revision notes, and we dive in, pulling out the really crucial stuff just for you. So if you're hitting the books, maybe prepping for something like the MSRA, and you're wading through pages of notes, well, we're here to help you navigate all that.
Exactly. Think of this deep dive as like a guided tour through your own revision material. Today, we're tackling a specific topic right from the MSRA revision notes you've shared. Renal Transitional Cell Carcinoma, TCC for short.
And our mission, it's simple. Make sure you walk away feeling confident about the key facts, the high-yield details you really need to solidify for your revision. We'll break down renal TCC systematically, following a structure that should feel pretty familiar if you're using notes like these.
Yep.
Let's jump right in then. What is renal transitional cell carcinoma? Give us the basic definition straight from the notes.
Okay, so at its core, renal TCC is a type of cancer. It starts specifically in the transitional epithelium.
Transitional epithelium. Okay.
Yeah, that's the type of tissue that lines your urinary tract. So the renal pelvis, which is part of the kidney, the ureter tubes, and also the bladder.
Right. So it begins in that lining, but specifically up in the kidney area, the renal pelvis mostly.
Precisely. And it's important to know, compared to other kidney cancers, it's actually quite rare. The notes say it makes up only about 5% of kidney malignancies.
Only 5%. Okay,
yeah.
that's definitely a number to flag straight away. It's kidney
Yeah.
cancer, yes, but the less common type from that specific lining.
Right. And because it comes from that transitional epithelium, it actually shares his histological features look similarly under the microscope to bladder cancer. Makes sense. Same tissue lining.
Oh, okay.
And it can show up either as a primary tumor starting right there in the renal pelvis or ureter, or sometimes it can be a metastasis, spread from cancer that started lower down, like in the bladder.
Got it. Origin, rarity, that 5%, and the link to bladder cancer.
Okay.
Now, what about the why? What causes it, or maybe more usefully for revision, what are the risk factors mentioned in your notes?
Well, like a lot of cancers, the exact precise cause isn't fully known. That's pretty common. But the notes give a really clear list of significant risk factors, things that definitely increase the chance of developing it.
Okay, what's top of that list?
High up and flagged as a significant risk factor is exposure to certain chemicals and toxins. And the big one mentioned is smoking.
Smoking,
Yeah.
of course.
Yeah.
Seems like it pops up everywhere as a risk factor.
It really does. The notes also specifically mention aromatic amines. Now, these are often linked to occupational exposure.
Occupational, like certain jobs.
Exactly. Jobs in industries dealing with things like aniline dyes or chemicals used in making leather, textiles, plastics, rubber, petroleum refining, even working with coal, coke, tar, and asphalt.
Wow, that's quite a specific list of industries. Is there a reason those chemicals affect the urinary tract in particular?
Yes, and this is a key point clinically. These carcinogens, these cancer-causing agents, are often processed by the body and then excreted, or sometimes they become activated in the urine itself. So as that urine flows through the renal pelvis and the ureters, it basically bathes that transitional lining in these harmful substances for a prolonged time. That increases the risk right where this cancer starts.
Right, so the body trying to get rid of them actually concentrates the danger right there. That makes those occupational links really important to remember.
Exactly. Other risk factors listed are things like chronic urinary tract inflammation, certain hereditary conditions, Lynch syndrome is named specifically, and also having had previous radiation therapy to the abdomen or pelvis.
Okay, so for revision, definitely nail smoking and that mechanism for the occupational chemicals. Then add chronic inflammation, Lynch syndrome, and prior radiation. Key associations there.
All right, moving from the why to the how, can you walk us through the pathophysiology? How does this cancer actually develop, at a cellular level, according to the notes?
Sure. So it all starts back in that transitional epithelium we talked about. The fundamental issue is the uncontrolled growth of these cells. They become abnormal or dysplastic and just start multiplying without the usual checks and balances. The classic cancer story cells going rogue, growing out of control.
Pretty much. And the notes point towards a genetic basis for this. Specific genetic mutations are involved. They particularly highlight mutations in the TP53 and FGFR3 genes.
TP53 and FGFR3. Are those usual suspects in cancer development? Genes involved in growth control?
Yes, they are major players. TP53 is a really well-known tumor suppressor gene. Its job is to, regulate the cell cycle, make sure cells divide properly, and trigger cell death apoptosis if they're damaged beyond repair.
The guardian of the genome, they sometimes call it?
Kind of, yeah. And FGFR3 Mutations there can mess up cell signaling pathways, leading to too much growth. So when these genes get mutated, the normal brakes on cell division are lost, and that really contributes to the cancer developing and progressing.
Okay, so the mechanism is specific cell type, the transitional epithelium, starts dividing uncontrollably because key regulatory genes like TP53 and FGFR3 are faulty. Help to connect the dots. We already touched on how common it is with that 5% figure. Are there any other key epidemiological points in the notes we should cover?
The main thing epidemiology-wise is really reinforcing that relatively low incidence. It accounts for roughly that 5% of all kidney malignancies.
Right.
The notes also, quite rightly, add a little disclaimer. They say incidence rates can vary, and you should always check up-to-date sources for the most accurate UK-specific data. It's just a good reminder that stats aren't static in medicine.
Good point. So 5% is the headline number to know,
Yeah.
but keep in mind it's an estimate and can shift.
Fair enough.
Concise section. Now, this is arguably one of the most critical sections for clinical revision.
Yeah.
The clinical features. What signs, what symptoms should make you think about renal TCC? How does a patient typically present?
Okay, yeah, pay close attention here for revision. The notes list the common ways it shows up. Hematuria, that's blood in the urine, flank pain, sometimes a palpable mass in the abdomen or flank, recurrent UTIs, or symptoms related to the tumor causing a blockage somewhere.
That's quite a range. Is there one symptom that really stands out? The most common clue?
Yes, absolutely. There's a very high yield point here. The notes state that the most common symptom seen in a huge majority of patients, somewhere between 75% and 95%, is painless gross hematuria.
Painless gross hematuria. Wow, 75 to 95%. And the painless part is crucial, right? Visible blood, but no pain. That's a massive red flag.
It really is. You see blood, but it doesn't hurt? That needs investigating. Other symptoms can occur, like dysuria, painful urination, urinary frequency or urgency, maybe flank pain, especially if the tumor is near the junction between the renal pelvis and the ureter, where it can easily cause irritation or blockage.
What about that classic triad we sometimes learn about? Hematuria, loin pain, and a loin mass. Is that common?
Yes, the notes specifically warn against relying on that. That classic triad is actually quite rare. It's only seen in about 15% of patients.
That's only 15%.
Yeah. So while it's good to know it exists, if you wait to see all three, you're going to miss the vast majority of cases. The real key takeaway is that painless gross hematuria, often on its own, is the dominant sign.
That's such a crucial point for revision. Don't wait for the full triad. Significant painless bleeding demands attention.
Precisely. And it's worth remembering, too, that some cases might be completely asymptomatic. They just get picked up incidentally on an imaging scan done for something else entirely.
Right. And what if the disease is more advanced, has spread?
Well, late presentations, unfortunately, often involve symptoms related to metastasis, the cancer spreading to distant parts of the body. The notes list things like hemoptysis, which is coughing up blood, suggesting lung spread, or pathological fractures, meaning bones breaking easily, indicating bone mets. Persistent back pain could also be bone involvement. And then the more general cancer symptoms: fatigue, malaise, unexplained weight loss.
Okay, quite a range of possibilities, especially later on. So with those symptoms, especially something like hematuria or flank pain, what else could it be? What other conditions are doctors considering? What's on the differential diagnosis list in your notes?
Yeah, when someone presents like that, the list of possibilities, the differential, is pretty broad. The notes really highlight the need to distinguish renal TCC from other kidney tumors, especially renal cell carcinoma, RCC, which is actually the most common type of kidney cancer overall.
Right, so job one is telling the TCC apart from the much more common RCC.
Exactly. And then because TCC arises from that transitional lining, you also need to think about other cancers from the same lining elsewhere. So bladder cancer and ureteral tumors need to be considered.
Makes sense. Same cell type, different location, potentially.
Right. And then, of course, you have all the non-cancerous causes for those symptoms. Things like kidney stones causing bleeding or obstruction, urinary tract infections, benign strictures, other inflammatory conditions. Lots of things can cause hematuria or blockages.
So the thinking process is sort of rule out the common kidney cancer, RCC, rule out TCC elsewhere in the tract, and then rule out all the non-malignant causes of similar symptoms. Helps structure the approach. Okay, speaking of figuring it out, how do doctors actually confirm it's TCC and crucially work out how advanced it is? What are the key investigations listed in the notes?
Right, the diagnostic pathway. It usually kicks off with some basic tests, often in primary care. The notes mention things like a full blood count, FBC, checking renal function with UNEs, urine microscopy to look for blood cells and other things, and urine culture to check for infection. Standard initial checks.
Standard stuff. What happens next if TTC is still suspected?
Then investigations get more targeted. Urine cytology is listed, that's looking at cells shed into the urine under a microscope to see if any look cancerous. It's more of a screening tool, though. The really critical step is often ureteroscopy. This involves putting a thin scope, a camera, directly up the ureter and into the renal pelvis. This lets the urologist actually see the lining, visualize any tumor, and most importantly, take biopsies. Tissue samples for histology. That's how you get the definitive confirmation.
So cytology points the way, maybe, but ureteroscopy with biopsy is the gold standard for diagnosis. Seeing it and sampling it?
Pretty much, yes. And imaging is absolutely essential, too. The notes really emphasize the role of CT scans. CT is vital, not just for diagnosis and maybe differentiating from things like kidney stones, but crucially for staging the disease. Assessing the tumor size, if it's invaded locally, checking lymph nodes, looking for spread.
CT's the workhorse for staging, then.
It really is. Ultrasound, KUB, kidneys, ureters, bladder is mentioned as an alternative, maybe in specific situations, perhaps if CT contrast is contraindicated, but CT gives much more detail for staging.
Okay. And what about looking for spread further afield, metastasis?
To check for distant spread, the notes list investigations like CT scans of the chest, abdomen, and pelvis. Sometimes a bone scan might be needed if bone mets are suspected. And PE scans can also be used for detecting distant disease activity.
Right, so comprehensive imaging paints the full picture of how far the disease has gone.
Exactly. And that extent, how far it's gone, is then formally described using the T&M staging system. The notes introduce this specifically for upper urinary tract carcinomas like renal TCC.
TNM, right.
Just to recap, T stands for the primary tumor, its size, how deeply it's invaded the wall. N is for regional lymph nodes, whether cancer cells have spread to the nearby lymph nodes. And M is for distant metastasis, has it spread to faraway organs like the lungs, liver, or bones. The specific combination of T, N, and M determines the overall stage, which is absolutely critical for planning treatment and predicting prognosis.
Okay, wow. We've defined it, looked at risks, how it develops, how common it is, how it presents, what else it could be, and how you investigate and stage it. Phew. Now the big one. How is renal TCC actually managed? What are the treatments, according to your notes?
Right, treatment. It's highly dependent on several factors. The tumor stage, obviously, its exact location within the renal pelvis or ureter, and also the patient's overall health and fitness for treatment. And the notes stress this requires a multidisciplinary team and MDT approach. Urologists, medical oncologists, radiation oncologists, all working together.
Not just one person deciding that. A team effort.
Definitely. Now, for localized disease cancer that hasn't spread, surgery is often the main treatment. The notes list several options here, things like partial nephrectomy, removing just part of the kidney, or radical nephrectomy, removing the whole kidney. There are also endoscopic techniques.
Endoscopic, like minimally invasive.
Yeah, using scopes inserted through the urethra, or maybe a small skin puncture, percutaneously, to access and remove localized tumors within the collecting system itself. The choice really depends on the tumor's size, grade, and location.
So different surgical tools for different situations.
Exactly. For instance, a segmental resection removing just a segment of the ureter might be okay for a small, low-grade tumor in the lower part of the ureter. But for more extensive disease or multifocal tumors or high-grade TCC, the standard is often a radical nephroenterectomy.
Radical nephroenterectomy. That sounds major.
It is. It means removing the entire kidney and the entire ureter all the way down to a little cuff of the bladder where the ureter joins. The idea is to remove all the potentially affected transitional epithelium on that side, assuming the other kidney is healthy enough to take over.
Got it. Tailored surgery based on extent. What about treatments besides surgery?
Yeah, systemic therapies come into play, especially for more advanced or metastatic disease, or sometimes after surgery that's adjuvant therapy to reduce recurrence risk. These include chemotherapy, immunotherapy, and targeted therapy. Radiation therapy is also mentioned as an option in some contexts.
Do the notes name specific drugs for those systemic treatments?
They do. They mention some common first-line chemotherapy combinations, often platinum-based, using drugs like methotrexate, vinblastine, doxorubicin, cisplatin, that's MVAC, or gemcitabine and cisplatin. For metastatic TCC that comes back or progresses after chemo, immunotherapy agents like pembrolizumab are listed as an important option now.
Okay, so specific chemo combos and immunotherapy for later stages. Any other treatments?
Yes, there are also local treatments mentioned, things like instilling DCG, that's Bacillus calmette-guerin, the same stuff used for bladder cancer, or a chemotherapy drug called mitomycin C directly into the renal pelvis and ureter. Usually this is done via a nephrostomy tube, a small tube placed directly into the kidney. This is typically for more superficial or low-grade tumors, trying to treat them locally.
Interesting. Local washes almost.
Sort of, yeah. And then for cases that are already metastatic, the focus often shifts to palliative systemic chemotherapy, aiming to control the spread and manage symptoms, alongside palliative surgery if needed, say, to relieve an obstruction caused by the tumor. The notes also mention removing lymph nodes, lymphodectomy, for certain high-grade cancers, and the potential role for adjuvant chemo after surgery in high-risk cases.
And follow-up after treatment. Is that covered?
Yep, briefly. It mentions a follow-up strategy based on the tumor's grade and stage. This usually involves regular checks, things like urine cytology, imaging scans, maybe cystoscopy to check the bladder too, typically every 6 months or so for several years, always watching for any signs of recurrence.
Okay, that leads us right into the next crucial question. Prognosis. What's the outlook? How do people do after a diagnosis of renal TCC?
Yeah, prognosis, it varies hugely, and this is where staging becomes absolutely critical to understand. The outcome depends primarily on the tumor stage at diagnosis, whether it has spread, metastasis, and how well the treatment works.
So finding it early really makes a difference.
An enormous difference. The notes are very clear. Early-stage tumors have a much more favorable prognosis. On the flip side, advanced or metastatic cases, significantly poorer survival rates.
Do the notes give actual survival numbers? That always helps make it concrete.
They do, and these numbers are, well, they're pretty stark. They really highlight why staging is everything. The 5-year survival rates listed based on outcomes after radical surgery show this really clearly. So for the very early stages, TIS, TA, or T1, meaning the cancer is just in the lining or maybe just slightly into the tissue beneath it, the 5-year survival rate is actually excellent. It's 91%.
Wow, 91% for early localized disease. That's really good.
It is. But now look at the next stage. For stage T2, that's where the tumor has invaded into the muscle layer of the renal pelvis or ureter wall. The 5-year survival rate drops dramatically, down to 43%.
Wow, from 91% down to 43% just by hitting the muscle layer. That's a huge drop. That invasion is clearly a major turning point.
It absolutely is a critical threshold, and it keeps going down. For stages T3, T4, N1, or N2, meaning it's gone through the wall into fat, maybe invaded nearby organs, or spread to regional lymph nodes, the 5-year survival rate is down to just 23%.
Only 23%.
And then perhaps the most sobering statistic, and definitely one to remember for revision, if there's stage N3 disease, meaning extensive lymph node involvement, or stage M1, meaning distant metastasis, the 5-year survival rate listed in these notes is 0%.
0% for distant metastasis. That figure just hammers home the severity once it's spread widely. That massive gap between 91% for stage T1 and basically 0% for M1 disease, that's the most critical takeaway on prognosis, isn't it?
It truly is. It really underscores why early diagnosis is so vital and why follow-up after treatment, looking for any recurrence while it might still be treatable, is so important.
Okay, final area then, complications. What sort of problems can arise, either from the TCC itself or from the treatments used?
Right, complications. The notes list several possibilities. The cancer itself, as it grows, can cause local invasion, spreading into nearby tissues and organs.
Growing outwards locally.
Yes, pushing through the wall like we saw with the T stage and affecting prognosis so much. Then, the most serious complication is distant metastasis, which we just discussed the grim outlook for. Spreading, as the notes specify, most commonly to places like the lungs, the liver, or the bones. Also, the cancer itself or the treatment needed, like removing a kidney, can obviously lead to kidney dysfunction or even complete loss of kidney function on that side.
Right.
And then naturally, there are potential adverse effects from the treatments themselves. Chemotherapy side effects, surgical complications, radiation toxicity, and so on.
All significant potential issues.
Yeah. And the notes wrap up this section by just reinforcing the point that timely diagnosis and getting the right management promptly are absolutely key to minimizing these complications and hopefully improving patient outcomes overall.
Well, that was a really thorough deep dive through your MSRA revision notes on renal transitional cell carcinoma. We've hit everything from the definition, those crucial risk factors like smoking, and those occupational chemicals.
All the way through the pathophysiology with TP53 and FGFR3, the clinical picture focusing on that painless, gross hematuria.
We navigated the differentials, the investigation pathway, with CT being key for staging, reviewed all those treatment options, from surgery tailored to stage to the systemic therapies.
And crucially, we really dug into the prognosis, highlighting those incredibly different survival rates based on stage, especially that stark outcome once you hit metastatic disease.
What really stands out to me reviewing all that is just how dramatic that cliff edge is in prognosis. Between the early stage stuff, confined to the lining, that 91% survival, and the moment it invades that muscle layer or spreads further, that T-stage jump from T1 to T2 and then beyond is huge. Understanding why and where that happens seems like the most critical piece for really getting this condition clinically. Definitely keep that picture in mind as you revise.
That's a great point. It really emphasizes the biology of invasion.
Thanks so much for joining us on this deep dive into your sources. If you are preparing for your MSRA, remember you can find comprehensive resources, question banks, notes just like these over at passmilray.com.
And for even more free learning tools and notes to help you get ready, do check out freemsra.com.
Best of luck with all your revision.